good afternoon, or good evening, wherever you are. I am Riza Lingwa, the Communications Manager at the Forestier Foundation, welcoming you to the special webinar hosted by the CAF Policy Institute of the Dennis and Lenora Forestier Foundation. Today, we are here to attend this webinar on the theme World Health Organization Digital Adaptation Kits, the new norm for digital health development. And this webinar is being organized within the framework of the Bonfire project. And moderating today's session is no other than Dr. Ngor Valerie, who is a senior health researcher at the CAFU Policy Institute and equally doubles as a Bonfire project coordinator in Cameroon. Ladies and gentlemen, once again, thank you for joining us, and I wish to remind us all to use the chat box to drop in our questions and contributions in the course of the webinar. And at the end of the webinar, at the end of the presentations of our panelists, we're going to have a question and answer session wherein we'll give the floor to all our participants to either ask questions or to make contributions. Dr. Valerie, you now have the floor to present today's moderator and to carry on the next session of this webinar.
Greetings to everyone. Say good morning, afternoon, or evening, depending on wherever you are joining this webinar. I want to thank you for being part of this new development in healthcare. We're actually going to be looking at a very interesting topic, a very topical issue in global health. We want to look at the WHO Digital Health Adaptation Kit, which is commonly referred to as the WHO DAC, which is actually the new norm for digital health development. Digital Adaptation Kit for antenatal care is actually an operational requirement for implementing the WHO recommendation in digital health globally. And the Digital Adaptation Kits are actually part of the SMART guidelines initiated by the World Health Organization, and actually consistent with antenatal care recommendation, generically applicable to digital systems. According to the World Health Organization, DAC for antenatal care is a software neutral application, operational and structured documentation based on WHO clinical health system data use recommendation to systematically and transparently inform the designs of a digital health system. Joining us for this discussion today, we have Miriam Kangu. She's a global health development professional, a digital health innovator, and a final year doctoral candidate in the Department of Epidemiology at the University of Ottawa in Canada. Her doctoral work aims to generate evidence to inform policy on improving performance-based finance equity program for maternal and child health services in Cameroon and the sub-Saharan Africa region. She's a founder and project lead of a digital health project called Bonfire, a prenatal management system which connects pregnant women to their healthcare providers and support them throughout their pregnancies up to 2 months after delivery, including emergency cases. Bonfire PNMS is an award-winning mobile application that recently won the Geneva Global Health Games that was organized in Geneva. She has been conceptualizing, designing, and complementing international projects on maternal and child health services, supporting health systems, strengthening and capacity building in Africa. Her current research focuses on the configuration, implementation, and contextualization of the WHO DAC tool for antenatal care within the Bonfire PNMS digital health platform to support pregnant women during pregnancy and postpartum in Cameroon and the sub-Saharan Africa region. She is joining us from Ottawa. Miriam, you're welcome. Also joining us is Donat Weleji, who is joining us from Belgium. Donat is an information technology expert with over 20 years of experience in IT. Donat is very passionate about open source projects and their adaptation to the realities of developing countries. And he specializes in designing and implementing IT systems based on open source technology. Donat firmly believes that software should be adapted to the specificities of the area where the software is to be used. Donat enjoys writing codes on Java, PHP, and JavaScript related programming languages. He is the lead IT developer of Bonfire PNMS Digital Health Project and has many other projects under his portfolio. Donat Weleji is the founder and chief technology officer of Donwell System based in Belgium. He holds a Master of Software and Internet Technology degree from Information Technology University in Copenhagen, Denmark. Also joining us from Cameroon is Dr. Kengafak Fobela. He is a medical doctor who graduated from the Faculty of Health Sciences, University of Boya, about a decade ago, has many feathers to his red cap. He is a trained statistician from the University of Edinburgh, Scotland, and a clinical radiologist from Polytechnic Federal School in Switzerland. Also, Vela has a master's degree in public health from St. Monica University Higher Institute and a frontline field epidemiology certified from the Center of Disease Control and Monitoring. He is a member of the Cameroon Medical Council and an assistant surgeon in training. He has garnered many research projects and published several articles in high impact journals. Currently, he is a research associate with the Dennis and Leonora Foretia Foundation and also the district medical officer for Bangem Health District in the Southwest region of Cameroon. Also joining us from Nigeria is Abdul Mumini Musa. He's a medical doctor as well and a specialist obstetrician and gynecologist with special interest in reproductive, maternal, and newborn child digital health, including endoscopic gynecological surgery. Having completed his elementary and secondary school education in Kaduna State, Nigeria, he attended the prestigious Ahmadu Bello University in Zaria, Kaduna State, Nigeria, where he graduated with Bachelor of Medicine, Bachelor of Surgery, MBBS. Dr. Musa has a postgraduate residency training at the Federal Medical Hospital, Katsina, the National Obstetric Fistula Center in Katsina, and the Modibo Adama University Teaching Hospital, where he has been using digital platforms such as electronic medical records. Dr. Musa has a master's degree in public health and many other certificates, including the Certificate of Leadership and Management in Health, and also a degree, MBA degree focusing on healthcare administration. Dr. Musa has worked in several organizations, both government and non-governmental organizations, nationally and internationally. We also have Sianga Mutola, who is also joining us from Zambia. He is a public health specialist with a master's degree he was a Master of Medical Science, majoring in public health from the University of Gothenburg in Sweden. Currently, he is the program manager for Global Affairs Canada project, tagged the sexual reproductive health and economic empowerment that support out of school adolescent girls' rights and skills at Care International in Zambia. Sianga has also worked at the Ministry of Health in Zambia for more than a decade, focusing on HIV care, STI, TB prevention project, funded by the Zambian government partners such as Churches Health Association of Zambia, the Center for Disease Control, Society for Family Health, and the Center for Infectious Disease Research in Zambia. In academia, he has been a clinical instructor and a nurse tutor at Lewanika College of Nursing and Midwifery, where he taught epidemiology, health promotion, occupational health, health information system management for about half a decade. Sianga Mutala, you're welcome for this wonderful webinar. Viewers, I want to believe you can hear me loud and clear. We are actually going to be looking at one very interesting topic, which has actually been on the global platform. Commonly, people talk about digital health, mobile health, telemedicine. And each time I hear about this, I remember how a colleague of mine was assaulted while practicing medicine and at the same time pressing his phone. And unknowing to the patient and the patient relative, they thought the healthcare provider was negligent about their disease condition because they were not aware that he was actually using his phone to do consultation as well. So my panel is actually going to be looking at digital health. And one of the questions that keep worrying is, I would like to know from them, what actually is this digital health all about? Can we actually inform our viewers what digital health, when you say digital health, what do you actually refer to? So, I mean, I can hear from any of the panelists. I don't know if we can hear from Miriam, if you could give us maybe a layman information or definition of what digital health is all about.
Thank you, Dr. Valerie, and thank you for this opportunity. So what I would say is it's a very interesting question you just asked. Like, what would you say digital health for a layman? I would just say in a simple word, technology. So anything that you are doing with technology to deliver care, or try to assist patient with. From a very simple perspective, I would just say the use of technology in delivery care. But normally digital health is actually an umbrella word, and it encompasses a lot of other things like telemedicine, m-health. But looking at it from a very simple, straightforward, I would just say the use of technology. It could be your mobile phone, it could be your laptop, it could be software to deliver care.
Thank you, Miriam, for this definition. And I will also be very happy if we could also hear from our IT expert, Donald Weleji. If how can we expatiate on what Miriam has just said regarding digital health?
Yeah, just to add, can you hear me?
Yes.
Yeah, just to add to what Miriam said, I mean, she just touched it. Basically, it's where technology meets health. I mean, to the layman. And I know a lot of people, when they say digital, they think only about maybe mobile phones or things like that. But no, this incorporates, it's very broad. It has to do with all the technologies that helps to deliver healthcare. So apart from, okay, we have mobile apps, as we have telemedicine, we have handheld devices on your body. And behind the scene, we have all these servers that make all these things work, internet connections, and all these various technologies. But to make it very simple to somebody who has not actually interacted with this, let's just say digital health is like transforming what you do manually. For example, when you go to the hospital and you have to fill your, let's say, hospital book with a pen. So one of the things of digital health is just to transfer this from the manual to digital world. So let's say rather than actually filling the hospital book on a sheet of paper, you're actually doing that on a mobile phone or on a screen. Okay, and on top of that, digital health also include analyzing the data collected. You know, right now everything is done manually, but now when we go to the digital world, things that have been collected, let's say on a computer platform, can be easily analyzed by statisticians, you know, and let's say data scientists, and you know, all these technologies that when used in the health domain constitute what we call digital health.
So from my understanding, digital health is actually an umbrella term that encompasses telemedicine, mobile health, and so many aspects relating the use of technology in health. Because most of the time people always talk about mobile health, and it gets confusing when they say mobile health. It's like maybe an ambulance services that is moving from one place to the other, or maybe a ship that is moving from one harbor to treat people from one place to the other. So I'm actually happy I'm sure our viewers are actually getting to understand what digital health is all about, and that mobile health is actually a component of digital health that simply defines the use of technology from the aspect of our phones to access healthcare and services. One interesting thing is that Sub-Saharan Africa is a continent with the highest disease burden and with limited number of healthcare providers. And again, more than 2/3 of African countries have actually developed and adopted digital health strategies. By implementing many of such strategies has actually been very slow. So the question I really want to find out is, are there some reasons why digital health has not completely scaled in many parts of Sub-Saharan Africa? I mean, I could get this from any of our panelists. If you could give us any, maybe some of the reasons you feel digital health has not actually really scaled to so many parts of Africa, despite most of African countries having different digital health strategies that have actually been adopted, but the practice of digital health is still low. Are there some reasons for this?
Let me take this, Dr. Valeri.
All right, thank you.
You would all agree with me that generally the investment in health across sub-Saharan Africa is suboptimal compared to other continents of the world. Given the Abuja Declaration of 2000, where African countries are encouraged to invest at least 15% of their budget to health. You agree with me that only few African countries have adopted the Abuja Declaration. For my own country, for instance, since that year 2000, we've not had a budget that has dedicated more than 5% to health. So one of the reasons we have to accept as a reason why digital health has not found a place in sub-Saharan Africa is the fact that generally the investment in health is very poor. It is so poor that it's not enough to invest in key healthcare parameters such as manpower, such as medical supplies in form of equipment, drugs, and other medical consumables. Given that this investment in health is not even enough to address these basic needs.
Okay, let me just continue.
Okay, yes, Doctor. Okay,
Yes,
we have Dr. Musa back.
Yes, let me just continue from where he
All
stopped.
right.
You know, his country is talking about 5%. We are at about 7-8%. You know, that's really small.
That is Cameroon.
Yeah, that's Cameroon.
All right.
Cameroon, that yes, it's actually, it actually cannot even afford, you know, the personnel. It can't afford equipment. It can't afford many things that digital health has to put into place. And you know, we have a lot of remote districts where they have no access to network at all. You know, also, you know, digital health, you need access to smartphones. We still have health personnel that cannot even afford. We need access to computers. We have many facilities in the suburbs, especially that don't have even computer. I mean, simple desktop. You know, the platform for digital health is a very big problem. And then, you know, coupled with the health policies, you know, it's not able to match out. So we have these drawbacks, and you cannot implement digital health when we don't have at least the basics. So that's where we are in Africa. We need to try to improve our health policies. We need to bring up the budget. The government people, the politicians have to put in, they have to take healthcare as a priority, like in other countries, in other continents, so that they can be able to match up and meet up with the demands. Yeah.
Thank you, Dr. Fobela. Abdulmimi, sorry, we actually lost where you actually give us and some information. I don't know if you have another thing to add to what Dr. Fobela had just said.
Okay, to further buttress my point on the fact that the financial commitment to health in sub-Saharan Africa is so poor that no one sees digital health as a priority. From my experience in Katsina, one of the provinces where I studied and practiced medicine, the Federal Teaching Hospital there is the only health facility that has so far adopted the use of digital platform in health. And this is a facility that only attends to less than 25% of the population. Katsina has a population of about 10 million. You agree with me that for a population of 10 million, to which only 25% has access to digital health, this is very important. It has to do with the financial commitment on the part of the government. Other factors that contribute to the poor acceptability and practice of the use of digital health in sub-Saharan Africa has to do with poor digital literacy. From my experience, I have some superior colleagues that have no basic knowledge on the use of basic software applications on the digital platform. So how do you expect such colleagues to be able to adopt and utilize digital health? So these and other factors which my colleague may add, I think some of the reasons why the adoption of digital health in sub-Saharan Africa is so far abysmal.
So Miriam, this discussion seems to be pointing out to issues relating to health policies, and then also looking at other aspects of governance, because if you look at it, it is not just the issue of digital health scaling through, but so many other factors are actually playing in the background. For instance, when you look at rural electrification in many parts of Africa, that is still far-fetched. Meaning most of these health facilities in these rural areas don't even have access to electricity. and then to talk about network access. So how do you think we can, what can we do to realize the potential of digital health in Africa from your own perspective?
Yeah, so just to add, thank you. So just to add to what my colleagues have said and to answer your question, this is a very important aspect. And looking at not just the political will or commitment of the GDP, but you also see that there is so much reliance on foreign aid. And so with this reliance on foreign aid, most of the countries or most of our governments in Africa, they focus more on other aspects like defense, Ministry of Defense and other components, but they don't put in much into health, as our colleague talked about prioritizing health. Now, the Ministry of Public Health most of the time may not be the only one responsible for health, because health is something that you work with intersectors. So when you start talking about taking example from rural areas, infrastructural issues, you start seeing that it's not only about the Ministry of Public Health, you need the Ministry of Communication, you need the Ministry of Transport, so even the Ministry of Finance, like it's some kind of intersectoral collaboration.
And rural electrification as well.
We need to start seeing that comprehensive way of holistic approach of addressing health, because if we don't look at it from that perspective, it becomes difficult for us to understand, and we keep like siloing the way we design our intervention. And also, we are just looking at the challenges, but we are not looking at some of the opportunities that we have. There are so many opportunities that we have in Africa. For example, look at sunlight. You see, you have natural sunlight, and there are ways you can do that. Like you have solar system, you have solar chargers that are coming into play. You can make use of that and sustain some of this digital health development or aspects that we are putting into, because most of the health facilities, you will see electricity, they don't have, like you just said, but you can just get, if the government is willing to invest into health, with solar system, you know, in the long run, it's cost effective. But having blackouts all the time and getting generator fueling it is also a substitute, but they have opportunities that they need to look into. And then you will see that it's just a matter of working together as a team, understanding that determinants of health is not only coming from health perspective, but other sectors that also have one or two things that interplay and intersect with how our health or how we need to manage our health. So I think that there are also other aspects that we want to look into. We talk about scaling digital health, and it's very challenging in most sub-Saharan Africa. But there is the irony, look at it in this other way. Most of the providers now in sub-Saharan Africa, they are using their mobile phones to actually deliver care, which is in one study just published last year, calling it informal health. And it's already kind of scaling more than the formal digital or health interventions, because you see, even right top to bottom, community workers are using it, health providers are using it, even at the level of the ministries. So it's already telling you that they are recognizing the importance of digital health. It's not just penetrating, but they see that the need is there, and it's actually facilitating some of their work. But now the policies that they have in place is also an issue, and is also one of the things that is actually slowing down this progress. So it's also the issue of transforming the right leaders, transformation of leaders, mindset, to understand why we need to invest into health. What are the importance of investing into health? A healthy nation is very important, because if you want to grow your economy, you need a healthy nation. And I think COVID-19 has actually brought us, open our eyes to see the importance of digital health. and to see why when you slow down progress in investing into your health sector, what the implications may be. Look at the way we had the lockdown went through for several months, and some people actually, there are some casualties that, there are so many things. The outcome was really fatal because some people actually lost their life, not because they would have, but access to essential services were not there because most countries neglected building their infrastructures to meet up the need of their population. So I think we should learn that lesson from COVID-19 to, open out. That's an opportunity to open our eyes and like, okay, what should we do and how can we improve on our infrastructures, our policies, so that if such a pandemic comes in future, we should not find ourselves in that same situation, because it will actually be, if we don't learn the lesson now, then I don't think we will be able to learn that lesson in the future. So I think that's the best I can say.
Thank you so much, Miriam, and viewers all over the world. If you are joining this webinar now, it is a webinar being organized by the Dennis and Lenora Forestier Foundation and is sponsored by Grand Challenge Canada and through the University of Ottawa. Dr. Musa, I'm coming back to you because you've actually a practitioner and obstetrician specialist, and you've actually been in touch with these digital health technologies in the form of electronic medical record at your place of practice. The question I want to pose is, how has the electronic medical record enhanced your service delivery at your place of work, if you want to look at healthcare access and utilization in Katsina State?
Thank you very much, Dr. Valerie, for this very important question. In fact, this is a very good platform to share my experience so far on the benefits of digital platform in terms of the electronic medical record on both us, the service providers, as well as the patient that access our care. Digital health technology in form of electronic medical record has so far revolutionized service delivery. On the part of the medical practitioner, I can tell you that one of the achievements so far we have made in terms of ease in the way we deliver our services has so far been provided by the electronic medical record. Unlike those days where a patient comes to you in the antenatal clinic, at times it will be difficult to retrieve the patient's file. Currently, we have no difficulty in has so far harmonized and centralized our access to data of patient in form of patient's file. In other regards, it has centralized service delivery in the sense that all healthcare providers currently use a single platform for their services. A patient comes to you, you want to request for a blood test, you easily click on your button, send the request to the laboratory technician, who within a second receives the request. And the only challenge he would have is that of moving the patient from the consulting room to the laboratory where the sample will be taken. And the same thing applies to other healthcare service providers like the pharmacists, the radiologists, where all the services are harmonized on the digital platform. And you can easily access those services, make requests for those services, and get your results easily. And the good thing about it is the fact that unlike those days where you tend to have missing results, you realize that you are planning a patient for a surgical procedure. Suddenly you are expecting to have a result that will guide how you manage that patient, only for you to realize that you have no access to that result. All this has been taken care of with the digital platform in form of electronic medical record. For the patient, it has built confidence in the sense that, for instance, in our facility, we have a form of wallet system whereby when a patient comes to the hospital, uh, before he accesses any service, he deposits an amount of money into his wallet in the digital platform. For every service he accesses, there is a real-time display of how his funds are utilized for those services. If he requests for a breakdown of how his fund is utilized, it can easily be printed out. This alone has made the use of electronic medical record so reliable, and it builds the confidence between us, the service providers, and the patients. There are so many benefits that we have so far derived in terms of revenue generation. I can tell you that because of accountability provided by the digital platform, uh, initially when we were not using the digital platform, the revenue generation was very poor. But currently, the revenue generation in the facility has increased by about 500%. And by so doing, the management is able to generate revenue and channel it into other aspects of making sure that service delivery is improved. More equipment are being procured, more repairs and maintenance are being done. And this is all courtesy of the advantage provided by the digital platform. Uh, Based on what I have said, you could see that the benefit of the use of digital platform is tremendous. And as such, I would encourage that more and more facilities in sub-Saharan Africa should adopt the use of digital platform for their healthcare services. In the long run, it's going to improve patient outcome, patient satisfaction, and it's going to build the confidence between the healthcare provider and the healthcare receiver. Thank you.
Thank you so much. You talked about wallet system in digital health, and that drew my attention to the aspect of health insurance, which means using wallet, a patient can actually go and deposit some amount of money into their digital platform or into facilities where they have digital access. And by doing so, they actually save for rainy days and thereby reduces or to some extent eliminate catastrophic healthcare expenditures that are actually commonly faced by families in sub-Saharan Africa. And that's actually very interesting to hear from your own experience in Katsina. I also want to find out from Dr. Fobela, do you look at this to also have some challenges if digital health platform or probably let me start from you back to you again, Mr. Are there some challenges uh, that you probably might have experienced, considering that every glittering surface, they somehow some level of silver lining. I mean, they are never 100% effectiveness in whatsoever intervention we might be using. So are there some challenges probably you might have encountered while using your platform in Katsina State?
Yeah, of course, Dr. Valeri, change is a very difficult thing to adopt and assimilate. For any new thing you introduce, there will definitely be some challenges. For us, from experience, the challenges have to do with policy making, infrastructure as outlined earlier, and secondly, it has to do with attitude, you understand? The attitude of the healthcare providers, uh, other administrative staff generally, in adopting the use of digital technology. In terms of the policy making, at every stage in the development of a nation, policymakers usually find it difficult to adopt newer things and to invest in those things. In fact, for digital technology to be implemented in our own facility, it took more than a year for the medical director to convince policymakers to adopt that platform. So you see, this is one of the first challenges we encountered. The challenge that has to do with infrastructure, as outlined earlier by some of our colleagues, you agree with me that at a point in time you're in Nigeria, you agree with me that our power supply, it's terrible to some extent. And wherever power supply is not stable, the use of digital platform will definitely have some form of challenge in terms of
Thank you, Dr.
powering
Your network seems to be a little bit poor. I'll take back our viewers to the topic of today, which is actually looking at the WHO digital health, especially with respect to antenatal care. We're actually looking at the WHO DAC to digital adaptability for antenatal care. We will try to switch into that. Last year, the World Health Organization actually released the digital adaptation kit for antenatal care as part of its smart requirement guideline approach to systematically reinforce clinical, public health, and data recommendation within the digital health. The DAC for antenatal care actually comprises about 8 interlinked components, each having a purpose, output, and the adaptation needed based on the country-specific context. The question I want to find out from Miriam and Donald, it would be good for us to actually hear how easy it is to adapt this into each country's national digital health platform. Actually, tailoring this question to you because you have actually been involved in developing a software or a mobile app called Bonfine, which actually refers to deliver well in the English language, and sorry, in Pidgin. And I want to know, can we have a little information about this Bonfine PLMS and how easy it was for you to, or how easy it is for it to adapt and incorporate some of this WHO digital adaptability toolkit? Maybe we'll hear from you, Miriam, first. Or probably we've not heard from Donald. We may start from Donald. Thank you.
I will leave the explanation of the digital adaptation kit to Miriam, since that's the expert. I'm just an implementer, somebody who implements the DAC. But the definition, I will leave it to Miriam to do better. Talking about the Bonfire application, it's an application that we did develop from ground up, given with inputs from people on the ground. So it's unlike other softwares that comes from, let's say, the West and be imposed on us in Africa. It's a platform that has been developed based on the specificities of contemporary people. So the main idea we thought of, a lot of people, a lot of women that are going to use this platform will be, let's say, not very literate, as one of the things that the Dr. Katsina said. So some people don't really know how to use digital platforms. So we tried to design in such a way that anybody can use it. So we did design various icons so that instead of actually typing something, so you cannot, maybe the person cannot write, but when you look at the picture, you can actually recognize exactly what the picture might be saying. So this particular app, when you launch the app, you have on the first screen, you have like 6 icons. And basically this icon just connects the patient, in this case, the pregnant woman, to the hospital. So we have an icon, for example, emergency. So basically the patient just presses this icon and the app takes the location of the patient to the hospital. And when it arrives at the hospital, a message is sent to a particular doctor to whom the patient is attached to. So the doctor receives the information and says, hey, this patient has an emergency. And then the patient actually, the doctor actually calls this patient and makes a follow-up. If we go back to the last question, which you just said, what are the problems that Africa has in implementing digital health? I think if you look at the way we define Bonfire, we have to start with something simple, something that is not difficult for people. Most of the problems we have in Africa is that you come to Africa with a very large software, so it's difficult for even literate people to actually go through it, and then it discourages them from using it. Now, if you take the Bonfire application, it's so simple that to train anybody to use it, it's really easy. It just takes maybe less than a couple of hours, and then you can use this application. Now, linking this application to the digital adaptation kit, when we started, we had no idea about the DAC. But then from various interactions between doctors, we could learn the type of questions that they ask to pregnant women when they come to a facility. Now, what did we find? We found out that at the end of the first design, most of the questions from African doctors were actually in line with the digital adaptation kit. So now, just imagine when you bring a digital adaptation kit to the doctors now, they'll be very happy because they can relate to it. It's something they themselves have actually designed unknowingly. Unlike a case where you sit in Africa and somebody in, let's say, America designs something and brings to you. You know, it challenges you and it makes you not, let's say, not happy to use the system. So actually what we have found out between the last couple of years and when we just got the digital adaptation kit, I think sometime last year, there is some convergence between what is already done in the Born-Find application and what we have in the digital adaptation kit. So now what we are doing is to try to bridge the gap, see the things or those processes that are defined in the DAC that are not currently in Born-Find and try to incorporate them in Born-Find. And in this process, we have the feeling that it will be easier for health practitioners in Africa to quickly adapt and use this tool. I will let my colleague Miriam to continue.
Thank you, Donald. Miriam, we understand the WHO DAC tool was just recently launched, and your app seems to have picked it up so fast. I mean, what strategy did you use? I mean, and then how easy was it to incorporate some of these tools?
Yeah, so before I start, I would like to address this, not my app. So
yeah, I mean, you're the founder, so that is why I refer it to you.
It's a teamwork. So let's say the Born-Find app. Okay. Yeah, so that's an interesting question, and thanks, Donna, for all the updates. So how easier was it is that when we started, as Donna just mentioned, that was in we started conceiving this idea 2013. So let me take you back to the journey. So 2013, when we conceived the idea, just like Donna said, you start from very simple thing. We were just looking, we didn't start by looking at even app, we just looked at electronic record. And then gradually the ideas keep changing, 1 or 2 consultations, and then before you know it, it becomes like a mobile application that is connecting to a web-based application. Now, what did we do? We designed the first version using the WHO Focus Antenatal Care Package. So like Donna mentioned, there are 6 features, but specifically the antenatal feature, we used a framework. So it's built using an underlying framework. And when you use an underlying framework in building a tool, it becomes very easy to adapt and contextualize it because you are actually following the standard of how that particular intervention or that particular tool should be implemented or disseminated. So because we use that World Health Focus Antenatal tool, it actually guided us, coupled with all the consultation and discussion we had with providers on the ground, like what Donna just mentioned, because it's not everything that, this thing has to do with contextualization and adaptation. So you need to also understand what is the reality on the ground, even if you have a framework in front of you. So you need to do this back and forth consultations. So with that, we implemented the first version. Moving forward, when the DAC tool came up last year, it becomes easier because it's still WHO that actually launched the DAC tool. And if you look at the DAC tool, it's actually following standards and incorporating elements of ICD. So in that way, it really helped to align what we had already designed in phase 1 or version 1 to the DAC tool. Currently, we know that the Born-Find, we don't incorporate all the elements of the DAC tool because it also requires a lot of investment. So, but we have close to 40% of most of the features based on, I think Donna can throw more light on that, based on based on the DAC tool, if you look at all the components and all the features that are listed on the DAC tool, you will realize that we have close to 40% already implemented. So what we are doing now is configuring it using those codes as defined in the DAC tool to align with what we had initially designed in the PNMS, which donor can throw more light at that level of configuration. But what is more important is that we also have elements that are not part of the DAC tool, because DAC tool is focused on the antenatal care, but Bonfire is not just about antenatal, it's prenatal, postnatal, and it encompasses other elements like family planning. There is also a DAC for family planning. We have not yet explored that detailing because we are focusing more yet now on the antenatal care DAC. So those are some of the, this is just how it facilitated our work moving to expanding to some of these elements. And thanks to the funding from Grand Challenge Canada, we have been able to actually configure a few of those components, which I think donor can throw additional more lights on that. So what we are entering into now is trying to now train these healthcare providers and understanding where their pain areas are, contextualizing it and adapting it slowly but surely. And you will agree with me, like what our colleague from Nigeria just said, change. So it requires, it's a gradual process, you require training and a lot of follow-up with workshops. But what is important is acceptability, accepting that, okay, this digital tool is important and I would like to use it, or we need it in our system. So once you accept, like I initially said, it's all about mindset. Once you are able to accept and know that, okay, there is the need for a tool like this to facilitate our work, to improve quality of care, then the change becomes gradual, progressively. And we are already, we've engaged the Ministry of Public Health, both at the national level, district level, and we are happy that they've also recognized in Cameroon the importance of digital health. They actually launched their own framework last 2 years, and that already tells you that they have that vision to go digital. So we are actually aligning to that vision and working collaboratively with the Ministry of Public Health to see how we can support and scale this project and expand on this implementation of the DAC tool in the context of Cameroon, and currently working in 4 districts. So I will leave it now to Donna to talk a little bit about configuration. And I remember Donald mentioned one thing to me, that the moment he saw the DAC tool, he was like, this is what we need. Like, he really liked that document. Because sometimes when we sit and we conceive, when you don't have an elaborate framework like that, to talk to IT expert, it's also, it's not easy, it's challenging. Because I have the health background, but that's an IT and a technocrat. So we have to sit on so many occasions to try to see how we can actually just understand each other, what we are trying to explain, what we need, what is actually the concept, and what do we really want. But seeing something like the DAC tool, I think it really made the work much easier. I think Donna can speak to that.
Okay, Donald, before I take over to you, because our time is gradually going, we are pushing closer to the end, basically about 10 minutes. And I want to plead with our audience, if you have questions to ask, please kindly text or write it in the chat box, and then I will go to present the questions to our panelists. And Donna, before, so we don't talk too much, I want to actually probably fine tune the question in still a bit related to what you said, because the issue of change came up. Change, we understand, is one of those social factors that it's a little bit very difficult, because it is buried in attitude sometimes, and it becomes, people gradually cultivate change or attitudes to norms. already in some healthcare systems in Africa, for instance, in Cameroon, in Nigeria, where there's already electronic medical record, probably the district health information system, DHIS2. We also have that in Cameroon as well. Now, looking at it, this digital health that you're talking about, including the WHO DAC tool, are you foreseeing the issue of a part of the configuration we are looking at, talking about? Are there some potentials of conflict when it comes to you bringing a new technology to come and face an existing system? How do you intend to marry this and then to avoid conflict?
I don't think that there's going to be any conflict. The reason being that in IT systems, we have something we call interoperability. So to be able to connect two systems, two systems have to agree on a particular protocol. So for example, let's say in Nigeria, we might call, let's say, we can only have maybe first and last name, for example, when you input a record for a patient. While in Cameroon, we have first, last, and middle name. So basically, in order for these two systems to work, because they're just names, it's just that the way they're presented in the two platforms are a bit different. So if you look at all the various softwares that you have called, HS2, EMR, all those things, behind, basically at a lower level, they're actually just digital information. So if you look at the way they have designed that, there are various codes that you can actually relate to actually medical information. So if you design a system with the DAC and you want to talk to another system, for let's say DHIS2, basically what the software developer just needs to do is to look at the records in the two systems and see how you can match the record from one system to another. And then we design what we call an application programming interface, which is an API, that now you can use to collect record from one system and map it to records to another system. In that way, you can actually take information from this side and then represent it in the way the other platform will understand it. So for me, I don't see any clash. It's something that they could synergize. And most of the systems that you have called are what we call open source systems. Open source systems are software that the code, it's out there. You can take it, play with it, and upgrade it. Okay, so add more information or add more functionalities to this particular software. So if, for example, a platform is using, let's say, a particular hospital is using DHIS2, okay, and another platform has been designed with the DAC, they could get developers who might now incorporate the DAC into the DHIS2. So you see that in this way, the two, let's say, systems can easily interoperate with no problem. Basically, all what you do, we design what we call adapters between the two systems. So to adapt the information one system and take it to the other one where you can understand it.
Thank you.
I don't know if I answered your question.
Yes, thank you so much. Yeah, because I've actually come across this word interoperability, and at one moment I was wondering if it has to do with a surgical procedure. Thank you for making that so clear, and I now get to understand that the interoperability is actually a means of letting two or more digital health systems to probably synchronize or speak to each other in when it comes to data collection, data information, and probably data analysis as well. I want to also look at this aspect of conflict from the aspect of clinical practice. I understand that when I actually saw this topic, I was curious and I had to open the WHO DAC tool to see what it was all about. And I noticed it was quite a very long list of variables. And as a clinician, I was getting worried that how will a doctor be able to consult a patient in Africa where we have a very poor doctor to patient ratio, and a clinician who is probably struggling to see 100 patients in a very few hours. and I have to start looking at some of these questions. I mean, so does it mean the system also have to create room for uh, other staff that will assist doctors to manage this system, because it might become very cumbersome? What do you think, Dr. Fobela?
Okay.
Looking at the aspect of clinical practice and then using a tool like the DAC tool that has a long list of variables. How do you see it in terms of clinical practice and then managing the
Okay, thank you very much, Dr. Valerie. Very interesting question, especially in a system where a doctor is liable to about 500 patients, sometimes up to thousands alone. It's really challenging. Those are some of the challenges. But like we said earlier, if the government is all advocacy, if they can advocate for more doctors, advocate for more health personnel, advocate for more midwives, they can be able to support the system. And moreover, it's an interconnective system where you can have some data collectors even at the level of the facility. You can have people to input all that data so that the doctor can just maybe work on maybe the diagnosis, the clinical material, and the management, so that it eases the patient. So it starts from the outpatient department. It can be somebody that can key in the data at that level so that it's not so cumbersome for the doctor to carry. Yeah, these are some of those challenges, and it's all advocacy. And we thank Bonfire for all what they've been doing to the districts here in Sub-Saharan Africa. What they have been advocating through the senior divisional officers with all their stakeholder meetings, even at the level of the ministry, so that these people can see the importance of this and really try to cut up those drawbacks so that they can implement the right way. Yeah, thank you.
Thank you so much. We basically have about 2 minutes, and I want to check if we have some people that have questions to ask our panelists before we run up the discussion. I want to thank all my friends, colleagues, and then international viewers, people attending this webinar from Nigeria, some also from Zambia, some also attending this webinar from Sweden, and they also thank those who are actually based in Cameroon and participating in this discussion. We also have some people attending from other parts of the world. I don't know if there is anybody that might have a question. As I want to thank the panelists for this very interesting discussion. I don't know if you may have 1 or 2 things to chip in before we run on.
Hello, mine is more of a contribution and an emphasis on the WHO digital adaptation kit for antenatal care. One component of the digital adaptation tool that is going to be very relevant in healthcare delivery is the aspect that incorporates WHO recommendations into the digital adaptation kit. You know, the focus nowadays on healthcare delivery is shifting towards evidence-based practice, which is guided by recommendations by expert bodies such as the WHO. So incorporating the WHO recommendations into the digital adaptation kit will greatly enhance evidence-based medicine, which in the long run would improve patient care. So I want to actually commend the World Health Organization for introducing such kit and for finding it important to incorporate their recommendations in it. Is going to help a lot in terms of evidence-based medicine. That's my own contribution.
Thank you, thank you, Dr. Musa Abdulmini. Do we have any other comments before we run up from our panelists?
Oh, maybe I just say that I'm just adding my voice to my colleague, because like I earlier just mentioned, the DAC2 has really facilitated our work. That I can tell, and I think Duna can attest to that. So it's really something that is really worth noting. like he mentioned. And just to add also, contextualization and adaptation now is the next step, and does not necessarily mean that everything on the DAC tool may be contextualized or adapt, because every context is different. But what is important is that it gives us that framework, that overview of what to do and how to go about it and to achieve whatever outcome we are going to achieve. So that's very important. And given that it's coming from WHO, it also makes the advocacy work easier, because the ministries of public health, they recognize themselves with WHO, and they understand the importance of using a recommended tool from WHO in the system, or trying to adapt it or contextualize it. So it really makes that advocacy route much easier, and it facilitates some of your consultants and consultations and activities that you plan to implement. So that's really something I just wanted to add to that. And thank you so much for that.
Thank you so much, Miriam. Donald, any summary or any information, especially with the fact that you've been involved in trying to configure and input some of these variables from the WHO DAC tool into the Bonfine TNMS software?
Well, I just want to say that will be an easy task, but gradually, as Miriam said, we have not completely covered the WHO DAC, but let's say we are about 40% of it. And as we gradually move, this is a back and forth process between the stakeholders and those using the system and developers. So it's something that we need to move right up to the end of it. But I think with the coming of the DAC tool, it has actually made our work easier. So now we actually know how to map what we have been doing to actually because the DAC actually has codes that can recognize by WHO. So now we can actually map what we are doing before. I mean, what I've been doing before with these codes, which is making the work very easy. And if we transport the data that we have now to a statistician using the DAC tool, then he can do very good analysis. So we are still working.
Thank you so much. For Bella, any last word from you?
We just want to implement for all what Bonfine is doing, and we say Africa can only go forward if we take off the challenges and go straight to digital health. It will help us get data and better health policies to help ensure the health of all our individuals and our nations. Thank you.
So thank you, the panelists. From what we've all heard from our panelists, what it shows is that digital health actually has come to improve effectiveness, efficiency, and quality of healthcare. And it is also one of those strategies to achieve universal health coverage. So I want to thank everyone who took the time to participate in this webinar. I also want to appreciate the panelists for also being part of this webinar. I want to thank the Grand Challenge Canada for funding this program, and then also thank our implementer, the University of Ottawa, and then also thank the organizer, the Dennis and Lenora Foundation, one of the biggest, the CAFO Policy Institute, which is part of the Dennis and Lenora Foundation, and one of the biggest think tank in Africa. Thank you so much, and thank you for being part of this. Over to you, Raisa.
Thank you very much, Dr. Riley. I think we've come to the end of this webinar. Thanks to all our panelists. And on this note, I'll be glad to close today's webinar. Thank you once again.